Hello everybody, it's my pleasure to speak to you about thermal ablation for liver tumors, complex cases. I have no relevant disclosures. So many guidelines talk about thermal ablation and they mention this size of 3 centimeters as being the ideal, less than 3 centimeters as being ideal for thermal ablation. I will contend that a simple ablation actually should be a lesion that is 2.5 centimeters or less, something that's round, a single lesion away from major or critical structures like the bowel, stomach, abdominal wall, bile ducts, and so on. Lesion should be visible on ultrasound and or CT, but also not so small that you can't see it, and you should be able to target the lesion effectively. The reason why 2.5 is because in many ablation systems, for example these two shown here, a typical ablation gives you a width of approximately 3.1 to 3.5 centimeters. So to get a decent margin of between 3 to 5 millimeters, the lesions should be about 2.5 centimeters. If it's larger than this, you might need to do something slightly differently in order to get adequate margins. So here in this picture is an example of what I consider to be a relatively simple lesion. It's away from the surface, it's away from major critical structures, easily visible. When you get the needle in through the center with standard ablation, you get very good margins. For more difficult cases, there are many alternate strategies. You can use high power ablation of multiple antenna, more advanced guidance like ultrasound fusion with GPS markers, contrast enhanced ultrasound, MRI guidance. You can use lipidol marking as well as some other techniques I described more recently, like this HEPA-KAGA technique, which means using intravenous or intraarterial contrast and cone beam CT to localize the lesion. Modification of the anatomy with hydro or pneumodissection, artificial ascites, using balloons to separate critical structures. You can induce a pleural effusion in pneumothorax and go through the diaphragm for lesions that are very high up at the hepatic dome. Flow modification of the portal vein or IVC with balloons. You can use jet ventilation to reduce the movement of the liver, confirmation software to assess adequacy of ablation, and then also remember the non-thermal alternatives like irreversible electroporation or reversible electroporation, as well as radiotherapy. So fusion ultrasound imaging is something that I use in almost every case. It's very easy to do. It just takes a few minutes. You have a transmitter and a magnet that provides you spatial imaging relative to a reference image, such as MRI or a CT. And ideally, the patient should not be moving, should be under general anesthesia, so that you don't have to keep doing the registration again and again. For small lesions that are difficult to see, I've found this really invaluable. For example, this patient with multiple hepatic metastases, the lesions are visible, but on a superficial or simple sweep through the liver, it can be hard to see them. But when you fuse, it becomes very easy, and here the needle is advanced through the lesion, fairly straightforward. Ablation is performed with standard technique, and you get a good margin. Different patient. This is the lesion on the MRI. On the ultrasound, it was difficult to see, but with fusion, we could faintly make out the lesion. When we gave contrast, in this case Sonoview, the lesion became a lot more conspicuous, and subsequently with the fusion, it was a relatively simple matter to target it and achieve a good ablation zone. Different patient, diabetes, cirrhosis, hepatitis B. Patient has mildly reduced liver function with ascites. Solitary lesion in segment 7 and 8, which was detected on ultrasound, was initially recommended for Y90 during the tumor board, but we found that during the Y90 it was difficult to localize the lesion. This is the angiogram. Only a small part of the lesion is enhancing a nodular appearance, and it was hard to get adequate dose to the tumor and spare the liver, because the liver function was slightly deranged and we did not want to damage too much of the liver with Y90. And so the decision was made to do an ablation, even though the lesion was larger than 3 centimeters. Actually, when the patient came, the lesion was already 4.1 centimeters. And this is a high power imprint microwave ablation antenna placed through the center, 150 watts for 10 minutes with hydrodissection. And this diagram shows the theory behind high power. More of the tissue gets ablated with the active zone of ablation, which means direct heating, less reliance on conduction, and therefore less effect of heat dissipation because of vessels. The so-called heat sink effect is much less with the high power ablation of microwave. And as you can see, for RFA, this is really a major limitation and major limiting factor, the heat sink effect. So the same patient, after ablation, good result, good margins. This is the infused fluid that was used for hydrodissection, and good ablation with no recurrence for this patient out to 1 year. Hydrodissection is done this way. I usually have a pressure bag with tubing, which is connected to a needle that's used to continuously infuse fluid. I'm also using fusion in this case. So this patient, 67-year-old male with several lesions because of colorectal mets. These lesions were subcapsular. Some of them, as you can see, this one's abutting the pancreas, another one abutting the diaphragm. So to protect these structures, hydrodissection was done. First, the lesion is targeted with the ablation antenna, in this case a new wave ablation antenna, and hydrodissection is being done simultaneously. When you have the needle in place and you gently torque the needle, you can actually lift the liver away from the critical structures, like in this case, moving the margin of the ablation zone away from the pancreas. The fluid helps facilitate that, and ablation is carried out. Same thing for the subcapsular lesion of the dome, fluid protecting the diaphragm, and then with the needle in place, torque that to move the lesion away from the diaphragm. Ablation carried out like this. Patient also had a third lesion. In this case, the fusion was very helpful to keep track of these lesions. This is GPS markers, and ablation done for this lesion as well. This is taken from the internet, showing that you can put some contrast in the fluid that you use for hydrodissection, so you can see that very clearly on CT. And here they've also done hydrodissection around the portal vein, and this image showing very nice fluid distribution around the hepatic hilum and portal vein. Different patient, multiple recurrent liver lesions because of colorectal mets. I use fusion to keep track of all of these lesions. Collation trial has shown us that we can ablate multiple lesions and have improved survival. In this case, multiple GPS markers to keep track of the lesions. Ablation performed sequentially. Sometimes the ablation zone from one lesion makes it difficult to see some of the others, and that's when these markers are very, very helpful to keep track of what we are ablating. So for this patient, I believe I had marked out 8 different lesions. We can also use Lepidol to make lesions more conspicuous. Here's a small lesion which was very difficult to see, not visible on a CT, only faintly enhancing on the arterial phase. On ultrasound was hard to see. This is intraoperative arteriopotogram, or CT-AP. The lesion shows a filling defect with hypervascularity on intraarterial contrast injection. In this case, Lepidol was used to mark the lesion, and subsequently with GPS tracking and fusion, the lesion could be seen. The Lepidol deposit within the lesion actually made it slightly easier to see this as a echogenic structure on the ultrasound. and subsequently this was targeted. Here CT confirmation showing the needle going right through the center of the lipidol deposit. Ablation zone, also we can verify that there's good margins around the tumor. You may ask, why didn't we just stop at the lipidol? Well, the complete response rate of TACE, even with such dense uptake within the tumor, is only about 70%. So with ablation, you're much more confident that we've gotten complete cell kill, and this patient had no recurrence of this more than a year later. Post-ablation confirmation software is now reported. There are many publications. Here's a good one that you can look at. This is a technique described in the Netherlands, the reference here, where CT arteriography is performed with a catheter in the hepatic artery to enhance the lesion both pre and post ablation, and subsequently the ablation zone is overlaid on the initial CT angiography to make sure that there are adequate radial margins in all directions. So, word about caution. Lesions that are difficult, you can run into a lot of problems. Here is a patient who had a diaphragmatic injury, and this was after ablation of lesion near the dome. In this case, the ablation needle went through the diaphragm and created a small pneumothorax. This is a lesion in segment 3 near the stomach. Post-ablation, there was thermal injury to the stomach. You can see that on the CT. Subsequently developed an ulcer of the stomach extending from the ablation zone, and this was seen intraoperatively. And also remember, if you're using RFA, overzealous ablation can also lead to skin burns. So just in conclusion, when you're taking on these complex cases, remember to slowly build up your practice. Start with simple cases, get good results, progressively go to more and more difficult cases, gain experience with ultrasound by doing many different ultrasound guided procedures such as biopsies, lines. I got a lot of my ultrasound experience doing thyroid FNAs. I think it's really important to slowly build up your capability and skills. Call for help, discuss with colleagues, with friends. Many of us are very happy to discuss cases if you need as well. It's really important to go slow to make sure that you don't just jump into the deep end and run into a big problem, because as the quote says here, he who fights and runs away will live to fight another day, but he that is in battle slain will never rise to fight again. Thank you very much for your attention. Happy to take any questions.